So this morning we were sitting with Dr. Batsdorf talking about longevity. And I don't want to paraphrase you, Dr. Batsdorf, and maybe you could comment, but he mentioned that as people with Chiari and Syringomyelia age, their disease may not progress, but the aging process may cause their symptoms to be more profound. And I think I just want to tie together why John is talking about longevity.
Well, thank you, Susan. There's an interesting condition which I think highlights the importance of what Dr. Oro was talking about. As we age, all of us lose some nerve cells, and the reason that we don't all deteriorate mentally and physically is that the efficiency of connectivity between the functioning nerve cells improves somewhat as we get older. But the important thing is that people with Syringomyelia of whatever cause have some loss of nerve cells, and the analogy is between people who had polio, and this was recognized many years ago as a post-polio syndrome. And the same can apply to patients with Syringomyelia, that there's not necessarily any change in the imaging, but there is, as the age-related nerve cell loss catches up with people, some recurrence of symptoms that may have been under control. And so my comment is only that the significance of what Dr. Oro was talking about is immense for people who have some underlying neurological loss of function, and if there's some way in which we can slow the age-related loss of nerve cells, that would be a tremendous gift to people, particularly people who have some neuronal disability. Thank you.
Any questions? Thank you. Yes, it's on. I have two questions, please. The first one, I'm curious about stand-up MRIs. I've read many times that people with Chiari should have MRIs done in the stand-up ones, and whenever I've discussed that with doctors, I've always been told, no, it should be lay-down MRI. They don't have them available, the doctors I've spoken with, but they always tell me it's irrelevant whether it be stand-up or vertical or horizontal, excuse me. And so I'm curious what you have to say about that, because what I've read is always referred to Chiari as you should stand up and have it examined that way. And then my second question, if I may, I'm curious if you've ever heard of one of the symptoms after a surgery, a decompression. Have any of you ever heard of one of the symptoms being regrowth of bone in the mouth? Thank you.
Okay. So, no, well, either.
I'm still thinking about your mouth question. I'm not sure about that. I have to hear more about that. But bone regrowth is a problem for sure, as I highlighted, in adults and kids. Used to think adults doesn't happen as much, but it definitely does. And we do a lot of these 3D scans now to look at that bone before we go back if we have to. But the upright scans, it's really interesting. Yeah, it's a great question. you have. And a lot of families come to me, they really want to get one. You know, insurance rarely approves it. You often have to pay out of pocket, which always worries me, because I don't think or have seen in my practice that that really changes decision-making for what I'm doing. It makes sense like it would, right? You're upright and things should just sag and look so much worse. A lot of the symptoms are when people are up, particularly for the CSF leakers. You know, they have such a bad problem upright, right? It's very postural, but the films don't really show that. The MRI quality upright is so much worse than our usual coil because they can't get as close to the head. But I'd love to hear what others think, how they, if they use it routinely in their practice and have found utility that they didn't get, you know, with a standard MRI. There are a lot of things we're learning about prone and supine MRIs. That's different, but being upright, I think, is something that I have not incorporated yet, mostly because it's so hard to get approval. What others think here?
I actually have a couple slides in my talk.
Oh, great, Earl.
That's showing the difference, and there's, to your point, clearly variations, but I think, at least in my practice, I don't know if the others, that doesn't really change my decision process, but I think there probably are definitely some roles for it.
Okay, that's good, so maybe we can wait.
I would just like to say that patients, particularly patients who have history of hypermobility, I get MRI scans. I think there's a whole, what shall I say, disconnect that we tend to get imaging studies related to the position of the imaging table. And this is true for many conditions, that we image people not in the symptomatic posture, but in a posture where symptoms are minimized. But I do very frequently get upright MR scans, particularly of the craniocervical junction, and upright inflection and extension.
Yeah, good point. I love the dynamic scans with flexion extension. Those are used more routinely now. I think they're really good, but you're right, I get a lot of those supine. And what does that mean versus upright? So this is really good discussion. What do you think?
I agree completely. And I guess the question I have for myself and for others is the brain buoyant? I know, would it slump just because of the position or not? Or is there enough buoyancy? I don't know that.
Wish we had better answers.
Hi. I'm gonna dive in. I'm gonna take my chance at this point. First of all, I'd like to just say my name's Helen Williams. Many of you will know who I am. Morning was really good. I love this focus that John was bringing onto oxidative stress. There are several points I'd like to make. First of all, it was good. Thank you. The other thing is, this neuronal loss that Dr. Batsdorf was mentioning, the concept that I'd like to float is that this is related to the fact that these disorders are chronic compartment syndromes, and they involve very minor microvascular interruptions in the central nervous system that are happening on a regular basis as we move our bodies. So as soon as you get an obstruction to CSF flow, you're creating pressure instability in the central nervous system. And this creates ischemia on a microscopic level. And this creates oxidative stress in the central nervous system, and it damages those neural stem bodies. With regard to the last bit, and the reason why I really had to shoot my hand up, is this CSF leak. Because this pressure instability doesn't just involve high pressure, it's low pressure. And it's this yo-yo between high and low pressure that really is the crux of the point that I'm trying to make, which is what molds this tissue, what depletes the tissue, and what gives us all these symptoms that we're all, we're all familiar with. So this slump and this loss of buoyancy, the trick that we have been missing, my passionate belief is, the trick that we've been missing, including Williams B missed, is the CSF leak. So the first paper that he ever published on this subject in the early 1960s, 1963, a girl fell out of a tree. She had an acute onset syringomyelia following falling out of a tree. And he never got to the bottom of this. He put it in his MD thesis, and I have a very precious copy of that paper. But this is where things went wrong, so far as I'm concerned. Is that those doctors who introduced Chiari surgery before MRI scans, they were completely oblivious to this possibility that CSF leaks and slump, and that was his word really. He liked slosh and slump, and syringomyelia were his favorite words. And this is the trick that we have been missing. And until we can somehow get to the bottom of this, and one of the main problems that we have with getting to the bottom of this is that this is a dynamic phenomenon. And this is something that the fetal medicine surgeons have observed. The leaking that comes out of a spina bifida lesion in utero comes out in jets. It is not a trickle all the time. It is jets, and it's related to fetal movement. And as they move and flex and extend and flex and extend, amniotic fluid goes in, and amniotic fluid cells become viable within the spinal cord, and also jets of CSF come out. So this is a dynamic problem. And if we have patients lying on boards having MRI scans or sitting up having MRI scans, we are not doing an exercise test for the central nervous system. And this is my true passionate belief that we are getting to the bottom of exercise testing for the heart. We give technetium scans. We do things that weren't in my wildest imagination when I came out of medical school in 1989. But we need a exercise test for the central nervous system. And I haven't got the foggiest idea how we're going to do it. But this is the point that this is the conclusion that I've come to after what can only be described really as 60 years of research, because his work and my work, they merge. Yeah, from 63 to 23. That's what I'm offering as a perspective. Thanks.
Thank you for that. Appreciate it.
My question was for Dr. Grant. I was wondering, you were talking about the ultrasounds, and I was wondering how that differs from MRIs or other scans. What do you see the reasoning behind the ultrasounds over other scans?
Yeah, I guess right now it's a good question is used for me more of an intraoperative tool, at surgery. So it's not something in the clinic you could go and get an ultrasound and see what it might look like, because the bone will block the view. Although there are new ultrasounds coming that we can penetrate bone, but the standard ones, say in the clinic or something, you can't see through the lamina or through the bone unless you have a defect back there. So it's really something at surgery where you're using, once you removed the bone, the suboccipital bone, from a Chiari decompression, but it's very dynamic on ultrasound. You're doing live video, so you can watch the pulsations that we're just talking about, the tonsils and what's happening, but it's patient's flat, right? So it's a little bit different, but at least you could see dynamically with the heartbeat, with every pulsation, what is happening before you open up the dura. So I think we don't quite know how to apply it yet, but I'm learning more and more the more I use it. So that's why I've been using it more routinely. Because in very young kids, you might use ultrasound to say, okay, we did the decompression, things look beautifully on the inside. Maybe we're not going to open up the dura in a very young baby or some 2-year-old, because there's a little higher risk of complications for that young baby. Maybe the decompression's adequate with the bone alone and not doing a big patch and opening up and potential CSF leak, things like that. So that's how we apply ultrasound. I thought you were asking about the focused ultrasound I highlighted, which is something new in our field, and that's very exciting. That's where we're talking about circuitry and nerve restoration and how to prime and rewire what's already there. I think that's very exciting, and that's called focused ultrasound. You might see that being done The high frequency ultrasound is what people get for essential tremor. You know, these tremors that people have, and you can now ablate a very tiny focus in the brain with called high frequency ultrasound. It's completely non-invasive, which is amazing. You don't have to stick anything in the brain. You know, immediately that tremor goes away. It's very exciting, very gratifying. But there's a low frequency version of that, which I think is going to be really interesting for using it for epilepsy and some other things that we're looking at, OCD, obesity. There's a lot of things coming of how to modulate current brain circuits. So ultrasound, you know, it's coming back. It used to be the most primitive tool we had, but getting more sophisticated.
Yeah, and to follow up on that, appreciate all that information. You know, it's fascinating. So the patient comes into the operating room, they're supine, they're on their back. The anesthesiologist is going to put a breathing tube in, tape things all up. The patient is going to be rolled prone, so face down on the operating table. Most of us use a 3-pin headrest because it's very secure and nothing can move. I used to do about a 3-centimeter shave along the back. You're going to make a midline incision. You're going to look at the bone. Most people, it's about 3 centimeters by 3 centimeters, but you use your MRI scan to guide you into this opening, if you will, of the bone. It doesn't have to be excessive because the brain can slump, and if you make it too small, it's just not going to relax enough. So we're taking off the bone and the subocciput, what's called the subocciput right back there. Arch of C1, for the majority of patients, is going to be resected. The back rim, it's thin bony rim. Rarely you might have to trim a little bit of the upper aspect of cervical too, because some people have herniations way down there. But the best part and the point is that once the bony work is done, patient is lying down, face down. Then we use some sterile water and we fill up the cavity a little bit. And then these high quality ultrasounds are available now in our hospitals. We take the ultrasound and we put it in the water, if you will. You don't press on the dura membrane itself. You just hold it there, and then you watch the TV camera that's there, and it's black and white. At least ours is. And it's just unbelievable, really, in a lot of people. So these are the cerebellar tonsils. This is the spine. And there's almost, if you will, a trapping here. And everybody's herniation is going to be a little different. But with each heartbeat, with the ultrasound here, the dura is not yet open, you can see what's going on. I mean, you can see with each heartbeat how it's jamming that and creating that buckle, if you will. Can you imagine when people cough and sneeze and that happens? What's going to happen? You get this blocked up CSF and it's going to blow your head off. My head feels like it's going to pop off, doctor. Use different things, etc. But the point is, it's been very educational to do the ultrasound, as Dr. Grant noted, because it tells us what the pathophysiology is, gives us a sense of the severity. We then turn on the color monitor to look at the blood vessels so we know if there's any aberrant or vessels that aren't going to or might be in our way that we have to be cautious about. And then usually most of us will do a linear incision, Y-shaped in the brain area, open that up so it gives you a triangle shape. You may or may not need to shrink the tonsils. If it's severe, chances are you're going to have to reduce the tonsils to some degree. And now you've got this triangular opening. I used to use grafts very early on in my practice, but what we moved to is a small incision above that bony inion. And then I'd use pericranium, the lining on the skull, which is soft, pliable, yet strong. You tie it, you sew it at each of the 3 corners, and then tiny, 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 tiny little stitches all the way around. Before you're fully closed, you irrigate with a little water to replace some of the spinal fluid that's been lost. After you get it all closed, you ask the anesthesiologist to give the patient a big breath, and that area will expand. And if you have any leaks, then you need to oversew that. Often they may be in these upper corners. You get a little piece of tissue, underneath the scalp. You sew that in and you test it again. You want to make sure that you have no leak. Then we used to use a hydrogel type glue. There are different adhesive things that you can push on top of it. And then a nice steady closure, meticulous closure of the wound. I was an academic neurosurgeon for many years, and it's not unusual in academics to allow the resident, the neurosurgical resident, to close the wound, and the academic, the main surgeon, leave the room. You don't do that, at least not in Chiari. I mean, probably shouldn't do it in any, but yes, you can have the resident close the wound, but the faculty member needs to be there, or the main neurosurgeon needs to be there, because that's the most critical part. Is we want to get it sealed. You have a little leak, you're going to end up probably having to go back. And then I thought, well, why weren't we reconstructing some of that bone? So designed a titanium plate that's very bendable. It doesn't crowd it, but it recreates some of the skull structure that has been removed to allow the muscles to reattach to it. And then a meticulous closure of the incision. I think that's crucial. The attending, the main surgeon needs to at least be in the room. Yes, the assistant can do it. Assistants are going to have to learn, right? But meticulous, all the way to the closure of the skin, put a nice dressing on. And I think that's why the Chiari community overall has developed a pretty good track record, if you will. You can always do better. We're always going to refine it more, as some of the things have been pointed out. But anyway, just wanted to share what it is that we end up having to deal with.
And then, thank you for that. That was wonderful. This is my first conference, so I'm a little nervous. But my other question was, is it possible to be diagnosed with multiple diagnoses of Chiari? Can you have Chiari 3 and 2? Or do you just have 3, you can't have 2, or vice versa, 1, 2? And then my other question was, is decompression surgery something that Chiari patients with 2 and 3 get, or is it just mainly for Chiari 1?
Well, a lot of this discussion today is really all about Chiari 1, and that goes along with Chiari 1.5. It's very, very different than Chiari 2. A 1 doesn't become a 2 or a 3 or a 4. These are very separate entities that this Hans Chiari and way back when categorized, but this conference is really about Chiari 1. So I wouldn't even read about the others because they're not relevant to likely the discussion we're having. Your other question was there a second part of that? The decompression.
Just the decompression. I was born with 3.
Yeah.
And they diagnosed me with 2. So not to be too personal about it. So that was kind of like, I don't know how I can have both.
Yeah, I would agree with you.
Decompression, because it looks a lot different. So I don't know how the decompression fits in with my 2 diagnoses. And it's just getting a doctor that knows what they're talking about. I find they bounce back and forth between the 2.
Yeah, that's a really important point. I mean, we treat these so differently. So the decompression, the surgery, everything is very different than anything we've talked about for 2 or 3. 4 is even a very different thing. We're not usually decompressing, but a 3 is a very more rare, but it's something that, we do end up having to decompress, but totally different than what Ruhoy just described. Some of those things are relevant, but it's really a very different animal, and we can talk, later if you want specifically about your case. But a lot of the discussions and the technique-related issues are Chiari 1 because it's so much more common. I just thought of something related to the question about the ultrasound and MRI, the upright MRI question. I think Benny was there, but there was this paper that came out of, I think, Virginia, when they started doing a bunch of intraoperative MRIs. for Chiari surgery. Do you remember that? I think John Jane Jr. presented this. And it was a long surgery, right? Can you imagine pre, post, and trying to find a use for that intraop MRI that your hospital's asking for, that you just put in and paid millions for, but something was very interesting, that before the decompression, it was not that crowded in the prone position, which always intrigued me. We don't get MRIs of the brain prone, and it's always supine, and it's always going to look worse. But I never thought of it, even the position change. I don't know if Dr. Batsdorf has experience. I know we talked about upright, but it's hard to do a prone head MRI. But it's just very little we've learned over the years because of our protocols. But do you remember that, Benny?
I know.
Yeah.
About this, but would say someone prone, is this supposed to be like what he's older out of it have? Still, we do a bit of impression when we see what we see.
Yeah. Maybe sleep on your stomach.
Hello, my question would be in regards to the longevity. Is there any research or data to support what a Chiari or Syringomyelia patient might expect their longevity to be compared to the normal population?
Well, that is a great question. I have not even considered that. What do Chiari patients deal with in terms of long life? Is it less than those that do not have Chiari malformation? I don't really know. I would think that an adequate, well-done posterior fossa decompression for Chiari follow-up scans will look good, that the longevity would be similar to someone without Chiari, but it's not a known question.
Can I ask a question to Ali?
Eileen.
Am I allowed? You talked a little bit about endocrine issues, that you now start thinking about. I mean, that to me has been always a curious thing about prolactin and cortisol and growth hormone. Do you test those now up front?
Very regularly, yeah.
And how do you advise us of, should patients be looking at that?
Yes. I mean, so especially when there's evidence of changes of intracranial pressure, whether it's high pressure or low pressure, or history of alternating, especially if the sella turcica, for example, is partially empty, and there's a flattened pituitary. And certainly if there's obvious brainstem compression because of the nuclei that are placed in the medulla oblongata, I regularly test the neuroendocrine axis. And largely because I'm not a surgeon, so I'm looking for other avenues of treatment for patients who are symptomatic, right? So that's why they're coming to see me. So, and I regularly find abnormalities of hormonal levels of that axis. And I'm not an endocrinologist, and not infrequently do I recommend or do I make a referral to an endocrinologist for better care, but at least I help to identify some of the reasons behind some of their symptoms. But ultimately, the root cause basically is related to the spinal pathologies that we see, and these are all connective tissue disorder patients. So there's a very important correlations for the work that I do, and then I usually, like I said, get an endocrinologist to sort of help out and collaborate.
Yeah, it's fascinating.
I have a question for Dr. Ruhoy also, kind of tying in with that, but you talked about the protein elastin, and I'm curious if you see a correlation between how Syringomyelia patients would do if there's a way to test elastin levels indoor.
So laboratory-wise, there are no real biomarkers. There are stains for elastin, actually, but that pathologists do, but that's obviously a difficult tissue to biopsy. So I guess the answer would be I don't know, and it's obviously would be a great research project, but I don't think I can get many neurosurgeons to biopsy the spinal cord for research purposes. But there actually is a pathological stain for elastin, and it's regularly done in skin pathology, and as well as some other organ tissues, but mostly in skin pathology. Or actually in some of the lung pathologists tell me that they do elastin stain. So there is the possibility, but it's probably not going to take place anytime soon. But it's a great question that I'd love to answer.
Thanks. That was part of the cone as well. So when I was diagnosed with Syringomyelia, they also found a pituitary adenoma. Is there possibly like the adenoma connection between pituitary adenoma and Syringomyelia?
I don't regularly see pituitary adenomas. I don't know of any specific epidemiologic studies that correlate the two. I know that in my practice, I don't regularly see adenomas. I regularly see pituitary dysfunction abnormalities, as I said, just from neuroendocrine axis abnormalities. And usually when there's a flattened pituitary, I find that there's a level of dysfunction, but there's no adenoma present on imaging in any kind of relative, frequent sense. So, and that's just my experience again. I don't know what statistically might be out there in the research.
Hi. I just wanted to ask a little bit more about connective tissue and what the possibilities are for intervening at that level. And I guess it's a question about treatment, but also about prevention. So for a lot of people, they don't get diagnosed until something catastrophic happens, and sort of initial diagnosis often happens in the neurosurgeon's office. But kind of looking back over our life courses, there are traumas and infections and a lot of things that I think actually might have been amenable to just avoidance of certain things or behavioral changes, had one known, let's say, since childhood, that one had certain types of risk factors. And so I'm just curious what you see as the potential for preventing or forestalling the need for surgery, as well as options for non-surgical treatment.
Yeah, I love that question because it really sort of ties into sort of what my entire training has been about, because I trained in both pediatric and adult neurology. So I sort of have this sense of like, I take a lot of pediatric history and I pick up on things that clearly things were at risk early on in life. And then I have a PhD in environmental toxicology. So I'm very much aware of environmental exposures and what they do to our bodies, specifically our connective tissue. So I sort of tie all that in. And I absolutely believe that there are ways of identifying early on for preventative and maybe even maintenance purposes, so that maybe it doesn't lead to a catastrophic kind of presentation that requires surgical intervention, is sort of my hope and my mission. But so I think it all starts with the history, frankly. And, I regularly talk about this, like the histories for patients require a lot of time, which, the current healthcare landscape doesn't really provide for doctors to give the right amount of time to really take full, extensive, comprehensive histories. And you really have to start from, sometimes I go as far as asking the mom, like, was the baby active in utero? So you could start as early as gestation, but obviously oftentimes they're an adult in the clinic, so you may not have the mother in front of you, but you can, ask about early in life kinds of events. And I regularly pick up on recurrent infections when they were young, multiple rounds of antibiotics when they were young, hernias when they're 7, so which is a connective tissue problem, right? So something isn't holding it, connective tissue is supportive, it's binding, it's protective, it's buffering. And you could pick up on certain diagnoses that they had as a young child that would at least suggest, obviously nothing is completely diagnostic, but start to suggest a pattern. And then you can, sort of intervene on a more preventative level. What that level is really hard to say, and it's very much often tailored or personalized based on where the patient is at the moment that you're seeing them. But it really does require a comprehensive history. It requires time. And then you just sort of have to focus in on, so what state of inflammation is their body in, basically? So, and how could you prevent it? Largely, Dr. Maitland was supposed to speak about the mast cells, which plays a large role because, as I said during my talk, the mast cell release a lot of different mediators that are mainly all inflammatory, a lot of proteolytic enzymes that just sort of love to degrade pieces of the body. And so we do have ways of managing mast cell responses. We do have ways of managing immune responses. We do have ways of reducing inflammation. And I think the sooner that we can recognize this in any individual patient and come up with a plan for them, the better off they'll be in the long term. And so that is sort of, as being a non-surgeon, that is sort of where I go with patients and what I do with patients. And hopefully I can help, obviate the need for surgery. But I'm much the chagrin surgeon, sorry. But, so it's a great question. And I think it's definitely something that more doctors need to understand and do more of for patients, if we had the time.
Speaking of time, we're going to take one more question, then we're going to break. I do want to make one quick note before we take our last question that Annie has very happily said that if there are any children from 1 to 3, 20. Yep. Okay. From 1 to the end of the session, she'll be happy to take kids and keep them out of your hair. So it'll be in the Regency room down the hall. So, and then she also said that she was going to do another support group meeting for patients tomorrow morning at 8, again in Regency. So anyone who wants to join. And we'll take our last question.
Thank you so much for your time. I'm wondering how you would begin the journey of finding if there are connective tissue disorders at play post-op, where you begin, what tests you might request, and if there are effective treatments, if there is indeed a diagnosis.
Oh, me? Postoperatively? Well, if I'm the one that's referred them to the surgeon, I basically usually have already recognized that they have a connective tissue disorder. So postoperatively, I very much focus in on helping their recovery. And again, if they have a connective tissue disorder, they likely have what we refer to now as like the septad diagnoses, which mast cell activation disease is one of them. There's, small fiber neuropathy, there's a level of dysautonomia, there's obviously the hypermobility, there's usually some gastrointestinal dysfunction, whether it's just constipation or just frank gastroparesis. So I try to help improve all of those functions so that their recovery is optimal. And we have shown that it is. So the more that you can reduce the morbidity from, for example, mast cell activation from the surgery. I mean, the body doesn't know the difference between a surgical wound and a knife stabbing, right? So there's an immune and inflammatory response, right? And the mast cells are very much a part of that. So we manage the mast cells, we manage the immune system, we manage the inflammation, we control their pain, we control their dysfunction, and we allow the surgery to heal whatever part of their, I'm assuming you're referring to like cranial cervical decompression of the Chiari, or, right? So we're allowing the healing process to take place without the body generating a massive immune inflammatory response that would impair optimal recovery. And so that's generally what I do for patients who are post-op.
About pre-op. I know we're all there.
Well, pre-op, as I said, I mean, I do a whole lot of work up preoperatively. I try to find every avenue that I could potentially treat, whether it's, I do a lot of pharmacologic management, but I really love to talk about, more kind of lifestyle options and more natural options, which I'm very much a part of. I do a lot of integrative medicine, and in some circles, they refer to me as an integrative neurology, because I really do believe that, it doesn't all require medications. And so, but I do an integrative approach. So I combine the two, and I guide a lot on nutrition and lifestyle options and breath work and meditation and neural retraining. I really believe in all of that. But then I manage with a lot of pharmaceuticals, because they do play a role, because they work. They're potent and they work. And they work fast, which is often what patients need because they've been suffering a long time. I'm not a real big fan of all the different supplements that patients are on. I don't really understand why so many are taking so many. And I know that they go to see a lot of doctors. In fact, many of my patients, by the time they're in front of me, they've seen 20, 30 doctors, and usually at least 2 or 3 other neurologists, right? So, and they've all been told to take these supplements from different providers, and they come in with bags of bottles. And, I don't think that's good medicine in general. I don't know what we're targeting with all those supplements. I don't even know if those compounds are bioavailable in the form that they're in. So that's where medications actually play an important role. I do a lot of pharmaceuticals, but I also incorporate a lot of other lifestyle options that would really help to manage a lot of the chronic illness part. Dr. Bolognese wants to interrupt me.
Since you mentioned the supplements.
Yeah.
A lot of these supplements need to be either up very best and very fast. So saying for at least 10 days before you sound them, it comes with coagulation. Work.
That is true. People don't realize that things like turmeric and boswellia and the omega-3s are all blood thinning. So, when you're going for surgery, you have to stop those. And very few doctors seem to tell patients that. And so in fact, at Mount Sinai at the EDS Center, we sort of have this, we have a protocol for patients who are going in for surgeries about all their supplements and what they need to know to stop. They also can interfere with some of the lab tests that we do. Like for some, there's a whole mast cell panel that I do. There's a whole, as I said, neuroendocrine panel that they do. Some of them interfere. And then there was this one study that I once read where they took the same bottle of a supplement and they did LCMS, which is liquid chromatography mass spectroscopy. And in the same bottle, each pill had a different amount of that compound. Some had none. So, you know, I think we have to be wary of all these supplements. I mean, anything you could buy off the shelf, like, is not going to cure. This is a chronic and complex illness that, you know, that those in my circle take very seriously, and it's not going to be cured by supplements. There isn't a magic bullet out there. So otherwise everyone would have it. Anyway, I think I went off the scope of your question, but so pre-op, I do an extensive workup because I find other avenues where I can at least intervene and treat, and hopefully, again, prevent further progression, further relapse, or, you know, hopefully prevent the need for surgery. You're welcome.
Awesome. So let's break now for lunch.